Hi there and welcome to the Real World Provider, where we're going to talk about peptides in clinic and what every provider needs to know. So if you've been in the health and wellness space for more than 5 minutes, you've heard the word. Your patients are asking about them, your colleagues are offering them, and social media is absolutely flooded with peptide content. And if you're a provider trying to figure out what's legit, what's legal, and what's actually worth offering in your clinic, then this episode is for you. And today we're going to deep dive into peptide therapy. We're going to cover the major categories like healing peptides, growth hormone secretagogues, immune and cognitive peptides, longevity peptides, and some of the newer players. And I'm going to tell you what the research says, where the legal landscape stands right now in 2026, and what you actually need to know before you start offering these in your practice. So let's get into it. So the regulatory landscape, where things stand right now. And before we talk about individual peptides, we have to talk about the legal situation, because that's where most providers either get confused or get themselves in trouble. So here's the backstory. The FDA maintains what's called a 503A bulks list, which determines the compounding pharmacies can and cannot compound. Peptides that land on Category 1 of that list can be compounded by a licensed pharmacy with a valid prescription. Peptides on Category 2 are considered to have significantly safety concerns, and compounding them is essentially prohibited. In 2023 and 2024, the FDA moved a bunch of popular peptides to Category 2. BPC-157, TB-500, AOD9604, and TA1. And these are peptides that clinics across the country have been using for years and suddenly became off limits for compounding. It sent shockwaves through the functional medicine and wellness world. But then, in February 2026, HHS Secretary Robert F. Kennedy Jr. announced that approximately 14 of those 19 restricted peptides would be moved back to Category 1. And that includes some of the biggest names: BPC-157, TB-500, AOD9604, Ipamorelin, CGHT-1295, TA1, Selank, Semax, GHK-Cu, KPV, and MOTS-c. And this was massive news. Now here's the important part, and I need you to hear this clearly. As of right now, the formal FDA reclassification list has not been fully published. We are in a transition period. The announcement has been made, the direction is clear, but the official regulatory paperwork has not been finalized. So what does that mean for you as a provider? It means you need to be working with a reputable compounding pharmacy that is on top of these changes. It means you need to verify the legal status of every peptide before you prescribe it. And it means you absolutely cannot assume that because something was announced in the news, it's a green light in your state. Stay in communication with your pharmacy and your legal counsel. Also, I cannot stress this enough. Category 1 reclassification is not FDA approval. These are not FDA-approved drugs. They are compounded medications that can be legally prepared by a pharmacy under a physician's prescription. That's a very different thing, and how you communicate that to patients matter. So let's talk about the healing peptides like BPC-157, TB-500, and GHK-Cu. So let's get into these themselves, and I'm going to group them by category so this makes sense clinically. First up, there's healing peptides. And the king of this category is BPC-157, which stands for Body Protection Compound 157. This peptide has been extensively studied in preclinical research, meaning mostly animal studies, and the data on the tissue repair is impressive. We're talking about gut healing, tendon repair, ligament repair, reduction of inflammation. And it works by promoting angiogenesis, the growth of new blood vessels, and by modulating growth factor expression. Clinically, providers have been using it for gut tissues like this IBS and leaky gut, and for musculoskeletal injuries, and even for post-surgical healing. Now, here's the honest truth about BPC-157. The preclinical data is strong, but we do not have robust human clinical trials, and that's just reality. So when you're talking to patients about this, you need to be transparent. The evidence is promising, but it's largely preclinical. You're using it based on clinical experience and emerging data, not based on phase 3 randomized controlled trial. That distinction matters both ethically and legally. TB-500, also known as thymosin beta-4, is in the same neighborhood. It's well studied for wound healing and muscle recovery. TB-500 promotes cell migration and has anti-inflammatory properties. And a lot of providers stack BPC-157 and TB-500 together for injury recovery protocols, and this combination seems to be more effective than either alone. Again, we're largely working from preclinical data and clinical experience here. And then there's GHK-Copper. It's a copper peptide. And this one is fascinating because of all its applications across multiple areas. It stimulates collagen synthesis, promotes wound healing, and there's even research on hair growth benefits. It's used both topically and via injection. For clinics using aesthetics, GHK-Copper is an interesting option because it bridges the gap between regenerative medicine and cosmetic applications. Patients asking about skin rejuvenation and hair restoration are often good candidates for GHK-Copper protocols. So let's talk about growth hormone secretagogues, which is Ipamorelin, CJC-1295, and Sermorelin. These are peptides that stimulate your body's own production of growth hormone rather than injecting a synthetic growth hormone directly. That's an important distinction for your patients to understand. Ipamorelin is probably the most popular one in clinical practice. It's a selective growth hormone. It stimulates the GH release without significantly affecting cortisol or prolactin, which is a big advantage over old secretagogues. Patients use it for body composition, recovery, sleep quality, and overall vitality. It's well studied and generally well tolerated. Then there's CJC-1295, which is often paired with Ipamorelin. CJC-1295 is a growth hormone releasing hormone analog. It extends the pulse of growth hormone release. When you combine CJC-1295 with Ipamorelin, you get a more sustained and robust growth hormone elevation. The Ipamorelin CJC combo is probably the most commonly prescribed growth hormone peptide stack in clinical practice. Now, I should mention that CJC-1295's regulatory status was contested for a while. It was one of the peptides that was removed from Category 2 in late 2024 and reviewed by the Pharmacy Compounding Advisory Committee. It's expected to return to Category 1 under the current reclassification, but again, verify with your pharmacy. And then there's Sermorelin. Sermorelin is the one in this group that's the strongest legal standing, and here's why. It actually had prior FDA approval as a diagnostic agent. The manufacturer voluntarily withdrew it from the market, but because it was previously approved, compounding pharmacies have a stronger legal foundation to produce it. And if you're a provider who wants to offer growth hormone optimization, but you want to play it safe as possible from a regulatory standpoint, then Sermorelin is your safest bet. Then we talk about the immune, cognitive, and metabolic peptides. So we'll move on to some of the more specialized peptides, which they help with immune modulators, cognitive enhancers, and metabolic peptides. Thymosin Alpha-1 is a big one. It's an immune modulator that's actually approved as a pharmaceutical product in over 35 countries, not just the United States. It's been used for hepatitis B and C as an adjunct in cancer therapy and for general immune support. During COVID, there was a surge of interest in Thymosin Alpha-1 for immune optimization. And the research here is solid. We have real human clinical data, not just animal studies. And this is one of the most evidence-backed peptides on the entire list. Then we have AOD9604. It's a metabolic peptide. It's a modified fragment of a human growth hormone that specifically targets fat metabolism without the other effects of a full growth hormone. It was actually approved by the TGA, that's Australia's FDA equivalent, for a period of time. For weight loss clinics, AOD is interesting as a complement to GLP-1 therapy. Some providers are combining GLP-1 medications with AOD to enhance fat metabolism outcomes. And the evidence here is well studied, but the human clinical data is still developing. Then we have Selank and Semax. I'm grouping these together because they're both Russian-developed peptides with regulatory approval in Russia. Selank is primarily used for anxiety and cognitive function. Semax is used for neuroprotection and cognitive enhancement. Both are available as nasal sprays, which is a nice option for patients who don't want injections. The research on both is solid with the Russian medical literature, though Western clinical trials are still limited. If you're going to offer these, know that you're working with international data and clinical experience rather than a large-scale U.S. trial. And then we have KPV as an emerging anti-inflammatory peptide that's gaining attention for gut inflammation specifically. It's a tripeptide that's derived from the alpha MSH, and early research suggests that it may help with conditions like IBS. This one is earlier in the evidence curve, so set patient expectations accordingly. Now let's talk about longevity, sleep, and hormonal peptides. These are the ones that your biohacker patients are going to ask you about. MOTS-c is a mitochondrial-derived peptide that's getting a lot of attention in the longevity space. It improves mitochondrial function and insulin sensitivity. The research suggests it may play a role in metabolic regulation and exercise mimetics, meaning it may partially mimic some of the metabolic benefits of exercise. It's well studied in preclinical models, and it's one of the peptides that are expected to return to Category 1. Epitalon is the telomerase activator. It's studied for its effects on telomere length and pineal gland regulation, specifically melatonin production. The longevity community loves this one. However, I want to flag that as of right now because it appears still to be on the Category 2 restricted list. It's one of the peptides that may not make the cut to the current reclassification. So before you offer this one, you need to confirm its status, don't assume. Then we have DSIP, Delta Sleep Inducing Peptide. This one is emerging, but fascinating for providers who are treating sleep issues. It works on sleep architecture and stress response. For patients who don't respond well to traditional sleep aids who want a non-sedative approach, DSIP is worth having in your knowledge base. The evidence is still emerging, so this is more of a watch this space peptide. Then there's Kisspeptin-10. This is a hormonal peptide involved in reproductive hormone regulation. It plays a role in the GnRH signaling and is being studied for conditions related to hypogonadism and reproductive function. This is still an emerging area, but for clinics doing hormone optimization, Kisspeptin is one of the ones to keep on your radar. So here's some practical advice and things that you actually need to know. Okay, I threw a lot of information at you and I know that, but let's bring it home with some practical advice for providers who are thinking about offering peptide therapy. Number 1, get educated before you prescribe. And I don't mean reading Instagram posts. I mean understanding the mechanism of action, the evidence base, the dosing protocols, the potential side effects, and interactions. If you can't explain to a patient in plain language how a peptide works and what the evidence says, then you're not ready to prescribe it. Number 2, partner with a reputable compounding pharmacy. And this is non-negotiable. You need a 503A pharmacy that follows the CGMP standards. That's FDA inspected and that has quality control processes that you can trust. Ask about their testing. Ask about their sourcing. And if a pharmacy can't answer those questions clearly, then find a different pharmacy. Number 3, informed consent. Every single patient who receives peptide therapy needs to understand that most of these are not FDA-approved medications. They need to understand that the evidence base varies from peptide to peptide, and they need to sign a consent form that documents this conversation. Protect yourself and protect your patients. Number 4, document everything. Your clinical rationale, your dosing, your follow-up plans, and your patient's response. If you ever have to defend your prescribing to a board or in a legal setting, your documentation is your lifeline. Number 5, don't offer everything. You don't need to be a peptide dispensary. Pick the peptides that align with your clinical expertise and your patient population. If you run a weight loss clinic, focus on AOD 9604, BPC-157 for gut health, and maybe the growth hormone secretagogues. If you run a sports medicine practice, BPC-157 and TB-500 makes sense. Be strategic, not scattered. So that's going to wrap this up for today. Peptide therapy is one of the most exciting and fast-moving areas in clinical practice right now. The regulatory landscape is shifting in a direction that should open up access for providers and patients, and that's a good thing. But with that access comes responsibility. Know your peptides, know the evidence, know the law, and practice with integrity. If you want to go deeper on this, there's training, protocols, and clinical mentorship with Slimming Grace Academy. We're building out a community of real-world providers who are doing this the right way. In the next episode, we're going to shift gears and talk about HRT clinics, hormone replacement, who can offer it, the legalities, and how to build an HRT practice that actually serves your patients. And you don't want to miss that.